cases coming up, one from Care Hospital, Dr.Suryaprakash and Kapardhi team, and the other one is from Yashoda Hospitals, Dr. Shashikant and Rajshekhar. We initially go to Care Hospital, see them for some time, then switch to Yashoda and come back to Care maybe. Over to you, Ajay, for this session. Suryaprakash sir, I think we have...
Good evening, Srinivas Kumar. First of all, am I audible to you?
Yes, we can see you.
First of all, congratulations for a successful program, and which is very educative, and so many interesting cases done. And from myself and my team, our gratitude to the TCT India, particularly yourself leading the team. So today, myself, Dr. Kapardhi, my senior colleague, Dr. Sudhakar Reddy, Kantilal Shah, and technicians, and Anu, and Najma, Madhu, Anwarji, many are there. And we have a case for RCA CTO. My colleague, Dr. Sudhakar Reddy, will give you a short history and angiogram findings. Dr. Sudhakar, please.
A very good evening. Greetings from Care Hospital, Banjar Hills, Hyderabad. Here is a 63-year-old male gentleman with hypertensive, diabetic, with history of low threshold effort angina for the past 2 months. ECG suggestive of normal sinus rhythm, LVH with RS pattern in the inferior lids. Echo, there is no regional valve burst abnormality with fair relief function. EGFR was 86 ml per minute per 1.7 meter square. Angio done elsewhere 2 months ago, showing left dominant system, LAD mild, mid LAD mild plaque, diagonal fair size vessel with osteoproximal tight lesion. Major OM is large normal, and dysplasia is filling from the epicardial and septal collaterals. Next.
LAD lesion,
diagonal osteoproximal tight lesion is there. Dysplasia filling retrogradely from epicardial and septal collaterals. Next. There is a mid-RCA long segment CTO, probable of more than 20 mm in length, with one collateral at the level of occlusion. Next. Coming to RCO, it is a proximal cap is here is ambiguous with lesion length probable of more than 20 mm. Distal vessel with reasonably good quality with collaterals from epicardial and septals. Coming to the JCTO score of 2. Thank you.
Thank you, Dr. Sudhakar Reddy. Now I will request Dr. Kapardhi to go fast because there are 2 live cases. They have to demonstrate what steps we have done for this gentleman.
Yes, good evening, Dr. Srinivas Kumar and team. And regarding this case, it is a RCA CTO. The strategy here is anti-grade wire escalation technique and with retrograde guidance. So here the collaterals, if you take the septal collaterals are poor, in interventional collaterals are poor, and only one epicardial collateral OM to PLV it is there. So with this we want to do the anti-grade escalation technique. So 7 French XB catheter was taken, engaged the right coronary artery, and left coronary injection, amplage AL1 was taken with the side holes, and then left coronary artery was engaged with a 5 French Judkin for guidance, and then subsequently we have taken the workhorse wire run through and Caravel support and Caravel microcatheter support we have taken up to the proximal cap. Then subsequently we have changed the run through wire into the exchange to field XTR, because basically our strategy here is a micro channel tracking. Here the lateral view is the best view, which is separated. Initially we thought ambiguous cap, but it was a tapered tip after the side branch, so that we can place the wire in the tapered portion of the cap.
Yes, I will interrupt Dr. Srinivas Kumar. The Europeans and those who are really scared about a lateral view, definitely more radiation, but I somehow feel the mid-RCA lesions, its view is very useful for wire cross and straight segments crossing of the RCA. And here there is a side branch also is there. We can take advantage of a balloon anchoring, and we can even place a eagle eye catheter, but there is osteal stenosis, though that IVUS guided puncture may be difficult in this case. But as Kapardhi told, initially always invisible collaterals may be there in your channel. So we opted for a soft tissue tracking as most of the Japanese feel. Then we
Yes.
can escalate the wire. That is a strategy.
Actually, here through invisible micro channel tracking, the fielder XTR successfully negotiated this CTO segment, and then we placed yes, now you can see how it crossed the CTO, and then it entered in the distal true lumen. Next you can say.
So just two quick comments just
Please,
for the
please.
for folks out there.
Yeah,
Number
please.
one, I mean, one way to avoid the radiation of the lateral views, you can do an extreme right lateral, so then there's less radiation to you. But
Okay.
the other thing that you showed really quickly as you went through those images is that you did go back to did an RAO shot. Very important, because a lot of times you think the wire is in a good place, and then you go RAO and you find out that it's in the margin or in the subintimal space,
Okay.
and that can be challenging. So always check that second view. The final thing I'll
we
mention
checked
is
in the
that
RAO, we checked in the LAO, we checked in the lateral. 3
Perfect.
views.
Yeah.
and then the last 2 points are that the dual injection
Yeah.
and the use of the microcatheter
Yeah.
are 2 ways that you can really improve not only
Yes.
your support with the microcatheter, but your distal visualization. Because once you cross in a microchannel, there may not be distal visualization, and you only really want to inject with the retrograde.
Yes.
So
Yes.
keep going.
Always we are cross-checking with orthogonal planes, so that we keep the wire in the intimal tracking, and ultimately it crossed the distal the CTO, and we placed the wire across the distal vessel, target vessel, and then advanced this caravel catheter, and then our job made easy. Then we exchange it to again through workhorse wire, and we removed the caravel by means of balloon trapping technique, and then subsequently we pre-dilated the lesion preparation by means of
1.5 and 2 millimeter
2
low
mm.
profile balloons we could
hydrophilic
dilate.
balloons. Yes, correct. And then we have taken after dilatation thoroughly, the pre-dilatation, we took the check injection. Yes, you can see.
We have done the IVUS here. Please read out the IVUS.
To see the distal vessel size, because the distal vessel become contracted actually because CTO, and then we have taken exactly the vessel to select the stent size. We have taken the distal vessel as well as the CTO morphology, and you can see the IVUS, you can concentrate, and here the vessel is almost contracted, is 2.3, but after giving NTG injection it was grown to 2.75 to 3, and then the CTO morphology, basically soft tissue is there. You pull back, you can show the IVUS.
CTO segment issue.
CTO segment you can see, please slow. And then the soft tissue with a speckled calcium, it is there
CTO
at
segment.
7 o'clock, 11 o'clock and 3 o'clock position. Some calcific speckles of the S, that is the calcium, you can see the trimark appearance, and so it is basically soft tissue with I think microchannel, that is a CTO morphology. That's the soft tissue that hydrophilic wire fielder XTR tracked the microchannels, and the taper tip we can easily see in lateral view, because the ambiguous cap in other views, actually the outside angio it was not shown that morphology. And then after pre-dilatation, the angiographic findings you can see. Next.
So last view.
Yes.
Now we are about to, we
So
maintained the
this is
ACT
the
around 300 with heparinization. He received 12,500 heparin.
Yes.
The size of the stent we are choosing the around 3 because the reference diameter came at 3 and 3.2 actually on the IVUS.
Just a question to you from me, Dr. Ferenc from Germany. I think your result after pre-dilatation looks really nice. I didn't see really huge dissected segments in IVUS. So did you think about the option to treat these patients with drug-coated balloons, just not to stent? Or would you definitely go with
CTO,
stent?
CTO PCI. We have done with DES many follow-up patients, absolutely long DES everolimus stents. Very rarely we see restenosis with overlap stents and all. Almost we completed 1400 CTOs over 14 years. So we are very comfortable with the long DES. And as you said, in specific occasions, with a small vessel, this thing we can avoid stents. There we use the DEB and side branch. Otherwise, we prefer to go with DES.
No, in general, durable polymer everolimus stents are superior to drug-coated balloons. Actually, even routine CTOs, even in ISR CTOs. So, routine everolimus durable polymer, we selected that option because it's long-term patency rates. And other intimal tracking was there. Wire, having had a subintimal track and entered the false to true, false true, then they may be considered. But here, because it is intimal tracking from proximal cap to distal cap, so drug-coated stent is it is apt in this given case. And 3 into 33 Zines
38 is the
38 3 into 38 and it is across that CTO segment from proximal healthy vessel to distal healthy vessel.
Okay.
Slightly. Cine. Yeah.
We do
And
not give too
that
much,
RV branch is protected with a wire.
do it.
And then the proximal that mild disease was also covered.
We can do.
Yeah.
సరిపోతాయి కదా?
Suriapraksh. Implement is sufficient. Sufficient.
Yeah, I'm going.
Yes. Deploying at nominal atmospheres, nominal pressure of 10 atmospheres. 10 atmospheres.
6, 8, 9, 10. Coming down.
Exactly near the proximal CTO, still some waste was there. Yes.
Wire.
Yes. Yes. We want to do high pressure dilatation.
Dr. Ferenc, what exactly you meant with regulating balloon? You are thinking, we generally think of using regulating balloon when there is a diffuse long segment disease where you can't place a stent or instant restenosis. You are mentioning regulating balloon here?
Yeah, there is some study ongoing in Europe in CTO segments.
Okay.
Long diffuse changes, but if you achieve a good flow and you don't have really limiting dissection, so you could even try to treat that segments with drug-coated balloons. And
So which
Dr. Antonio Colombo presented a concept that where you can focal stent
Take
and
three
if it is
balloon.
okay, you can just do regulating balloon provided.
and coming to this point, because 1 hour before we had a presentation from colleagues, according in stent restenosis treatment, and
yesterday we had in the diffuse CAD symposium is a concept of presentation where you dilate it and then you also treat it with a regulating balloon. If there's no major dissections and you would leave it, and FFR values are also checked in that, and if my FFR is okay, then as well as no major dissections, just a regulating balloon.
Three balloons.
Yeah, this will be definitely optional for patients with some tendency to develop instant restenosis.
Dr. Srinivas Kumar.
Yeah.
And presently the role of drug-coated balloons is in small vessels and distal diffuse disease and ISR.
Yeah.
I think
that's what we are following in India. But what sir is mentioning is in diffuse disease, they're conducting one trial with the regulating balloon versus regulating stents.
Right.
The central point, it looks narrow, no?
Yeah. Yes, we have to dilate now. Now we are taking the NC balloon 3 into 12, 3 into 10, 3 into 12 millimeter, and then we want to dilate that segment.
Sir, after dilatation, you will do IVUS and probably. Now, the important thing you have shown, can we go to Yashoda and come back to you finally in the end?
Definitely, Dr. Srinivas, please.
Suryaprakash sir, we are with you now. You can final comments. Dr. Cindy Grimes has joined us, waiting for next session.
Okay.
Welcome, madam.
Just Dr. Srinivas, we just deployed the stent. The proximal portion is under expansion is there. and then we take the 3 into 12 mm balloon and dilate it
3.5,
systematically.
3.5.
Next 3 into
Okay.
balloon post dilatation from distal to the proximally we dilated, and then subsequently we did the IVUS run. IVUS run, can you show, please? So IVUS run, you can see, IVUS you can see that distally the stent was optimally deployed with a good expansion and a good opposition, but proximally if you can take, just proximally you can take, proximally, yeah, yes, you can see here it is under expanded actually. Here you can see because the vessel size here is 3.5 millimeter. So we have taken next 3.5 balloon, next 3.5 balloon, and then we dilated the proximal half of the stent. You can see, yes, next, and then we ultimately got a good result with TIMI-3 flow.
Thank you, sir.
Thank you,
Excellent
Srinivas.
demonstration. And normally we thought it would take long time for CTOs, but luckily the software wire crossed and the job was easy. Thanks for showing a good case, and thank you for joining for TCT.
Thank you.
I think with your permission, we'll go break now.
Please.
Okay,
And
okay, thank you.
thank you, Ajay, and
Thank
thank you, Ferenc, for conducting the
Thank
session.
you. All the best. And
Now we
Thanks, all the best. Congratulations.
Thank you, Dr. Ajay and Dr. Fering.
congratulations. Thank you, guys. Bye-bye.
Bye.
Thank you.
Bye.
Namaste. I am Dr. A. Srinivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings to you the best wishes from FACS Foundation and TCT India South Asia 2021. In our live case learning case series, this video will bring to you the highlights and the important messages what we have learned in the RCA CTO PCI, which was done with IVUS guidance by Dr. Suryaprakash and Dr. Kapardhi of CARE Hospitals, Hyderabad. What we have learned is how to decide to use antegrade versus retrograde, and then if you have decided because of a faint trickle in antegrade manner, then how to decide regarding the wire escalation technique versus antegrade dissection and re-entry. Basically, as we understand that when there is a faint or CTOs with relatively recent occlusions, and especially when you think there could be soft plaque with faint microchannels, we always try to decide and use the wire escalation techniques, starting with very soft wires like Fielder XT, and then gradually again increasing the wires in a staged manner, depending upon in what stage you use it. And obviously this wire exchange need to be supported by the microcatheter technique. In this case, actually the caravel was taken initially, and then Fielder XT wire was used to cross the lesion, and lesion crossed relatively easily because probably of the presence of microchannels, which was again demonstrated later by using an intravascular ultrasound. Later, once the lesion is crossed, then it is always important to exchange this wire back to your regular workhorse wire by advancing the caravel catheter distally, and then the Fielder XT wire was changed again to run-through wire, which is their workhorse wire in the lab, and then serial balloon dilatations with a smaller balloon, then taking a bigger balloon was done, and then IVUS catheter was introduced to see the extent of the normal to normal segments, and also to see what is type of plaque was there in the CTO, and how these microchannels appear on the IVUS was very well demonstrated, which we all of us have seen and learned. And it's also important to assess regarding the calcifications, which was there for about 270 degrees in this RCA, and that's how the lesion bed preparation with NC balloons, initially with smaller balloon, later with the bigger size balloon, was shown as mandatory. And in spite of doing this, again after taking the stent, there was again small residual underexpanded portions, which was again post-dilated with a 3.5 bigger NC balloons to optimize the stent expansion and position, which is again very well demonstrated in the post-PCI IVUS runs in these patients. It was also discussed regarding the wire crossing, which are the ideal views to see. And Dr. Suryaprakash specifically mentioned that when you're trying to cross in the mid RCA, he felt that lateral views, which were supposed to be worried and less used, the Western and Japanese, were also useful. He found it. And at the same time, Dr. Ajay mentioned that if you are worried about too much of radiation exposure, then probably instead of left lateral, you could use a right lateral view, which gives less radiation to us. And again, the point of checking in both the contralateral and ipsilateral views, like what we call is views like RAOs, LAOs, and was always stressed upon to see the wire course so that you will pass in the intima to intima without getting into dissection planes. And once the wire gets into dissection planes, unfortunately, then the usage of antegrade dissection and re-entry could be done, which will be demonstrated in another case by Dr. Goyal from SGPGI. And this we wanted to demonstrate antegrade wire escalation technique, which was again very well demonstrated in this RC or CTO lesion. Then after the wire was crossed and the balloon dilatation was done, IVUS didn't show too much of dissections. Then the concept of treatment of this with only drug-eluting balloons was brought in by Dr. Ferenc, who was moderating the case along with Dr. Ajay. And then we all discussed and felt that as of now, what we use for drug-eluting balloons is basically for distal vessel, thin vessels and diffuse disease and probably instant restenosis. But Dr. Ferenc pointed out and brought a new research study going on comparing the drug-eluting balloons versus drug-eluting stents after the CTOs are opened, especially when you find a long diffuse disease after the opening of the vessels with the balloons. But Dr. Suryaprakash felt that they found the usage of everolimus eluting stents, especially even though there were long stents required and his long experience, they all found usage of drug-eluting stents to be quite good. And then probably less of patient TLRs and follow-up was highlighted with the use of drug-eluting stents. But the concept of focal statement with stents followed by diffuse patching up dilatations with the drug-eluting balloons, and later on checking with the FFR values, which was concept which was brought out by Dr. Antonio Colombo in the earlier lecture of diffuse CAD, was also discussed. And this concept needs to be further studied in these patients of diffuse coronary artery disease. Many of the times we feel the arteries are diffusely diseased, but once you treat them with nitroglycerin, the arteries could grow, and then probably instead of using a very long stent, the stent diameters could be limited. But obviously when you're using imaging like IVUS, you can exactly make out from the plaque extent from which place starting to which place distal, and take appropriate sized and diameter stents, and then post dilate the stents with again bigger sized diameter balloons so as to perform the PCI as what we call as optimal PCI implantation techniques. And that is how the IVUS helps in guidance of this CTO imaging and also CTO performance of PCI. That's how the outcomes in the CTO patients could improve in long-term follow-up. Thank you. Hope you all enjoyed these live case learnings of CTO PCI with antegrade wire escalation techniques with our IVUS guidance. Thank you all. Yours, Dr. A. Srinivas Kumar.